So today our topic will be wrist joint complex, foundation for evaluation, differential diagnosis, and prognosis. Our objectives are or is student will learn cognitive domain, foundations for evaluation, differential diagnosis, and prognosis of the shoulder joint complex, and how those foundations develop through performance and application, psychomotor domain, that increases from basic recall to complex evaluation and creation. All right, so we're talking about the wrist joint complex. So the wrist joint complex consists of your radial-carpal joint, your mid-carpal joints, your distal radial ulnar joint, and also your carpal metacarpal joint. So the radial-carpal joint is the articulation that joins the hand to the forearm. Your mid-carpal joints are your articulations of the proximal and distal carpal rows, and your distal radial ulnar joint is your articulation between the distal radius and distal ulnar, and your carpal metacarpal joint is your articulation between the trapezium and the first metacarpal, okay, which makes up what they call the CMC joint. Who knows what type of joint is the carpal metacarpal joint? It's a saddle joint. So that is one that is heavily assessed on as well, because you have to remember that it's a saddle joint, and so you have to remember that the orthokinematics for flexion and extension is concave on convex. Okay, so your orthokinematics is your swing and roll is going to be in the same direction of your glide and slide. Okay, that's with flexion and extension. And then if you know flexion and extension, you know abduction and abduction, which is going to be opposite orthokinematics. All right. So continuation with wrist radial carpal joint. So let's talk about the characteristics and articulation, which I briefly talked about in the previous slide. So the proximal joint surface consists of the distal radius. So you see the distal radius right here, okay, as it articulates with the scaphoid and lunate, and also pisiform and triquetrum being the proximal row of carpal bones. All right. So you have the radial ulnar articulate disc connecting the medial aspect of the distal radius to the distal ulnar as well. Your distal joint surface, again, we talked about the scaphoid, lunate, and triquetrum are the proximal row of carpal bones articulated with the distal radius. The radial carpal joint is deemed to have 2 degrees of freedom. It's also reinforced by numerous ligaments at the radial carpal joint. So you have numerous ligaments that reinforce that joint to provide stability, and that is static stability, right? Why would ligaments be considered static stabilizers? Because they do not contract. Good job. So that's foundational content. Make sure you keep that log, right? Then we talk about osteokinematic motions and the capsular pattern of the radial carpal joint. So the osteokinematic motions we know are flexion, extension, radial deviation, and ulnar deviation at the radial carpal joint. Those are your cardinal plane movements. The capsular pattern is that flexion and extension are equally limited. Now, when we talk about the capsular pattern, when does the capsular pattern of restriction present itself? So self says arthritis or something. That is so. So anytime someone has involvement of the joint articulating surfaces, that's when one typically presents with a capsular pattern. So if your patient presents with a capsular pattern, we are thinking, what are we thinking? So we're thinking some type of joint capsule pathology. I'll repeat that again. So when your patient presents with a capsular pattern, of restriction. We're thinking some type of joint capsule pathology. So what we're thinking is that the dysfunction or impairment, when we talk about connective tissue dysfunction, connective tissue impairment, we talk about something going on within the joint articulated spaces. So it could be osteoarthritis, it could be rheumatoid arthritis, something that's affecting the joints. It could be a loose body within the joint. Okay, it could be something like adhesive capsulitis. All right, it could be hemarthrosis, blood within the joint capsule. But we know if the patient presents with a capsular pattern, we're thinking that something is going on within the joint. Now, say for example, if someone does present with a capsular pattern of restriction, then that should direct you to a certain group of special tests, right? So I'm gonna stay here for a minute. So what type of special test would a capsular pattern of restriction direct you toward? So Jordan said that if a person presents with a capsular pattern of restriction, as physical therapists, we're thinking that the person has some type of joint pathology because it's within the joint if they presented with a capsular pattern of restriction. Now we need to be performing special tests that assess the integrity of the joint. So a capsular pattern of restriction should direct you to special tests that assess the joint capsule integrity. Now we don't just want to know the capsular pattern, we want to know why the capsular pattern is significant. And so that is why the capsular pattern is significant. So I don't know if I spent time on that in other lectures, but I want to make sure I did spend time on that before we get through all of these joints. Because everything has a meaning for why it is done. Okay? Everything has a meaning for why it's done. All right, so here are our cardinal plane motions: flexion, extension, radial deviation, order deviation, pronation, supination. Don't forget your foundational concepts of the planes of motion. Don't forget your foundational concepts of the axis of the motion. All right, looking at our loose pack position and closed pack position of the radial carpal joint. The loose pack position is neutral with slight ulnar deviation, and the closed pack position is extension with radial deviation. And here's a picture: loose pack, closed pack. Next, we're talking about the mid-carpal joint. So the mid-carpal joint, we know, is the articulation of the proximal row of carpal bones and the distal row of carpal bones. Okay? And these are joint surfaces that are reciprocally convex and concave. So in some areas you may have concave on convex or either convex on concave. So if you look at the visual, right, and you look at this, look at the lines, and you can see the joint surfaces change. So if you look at my arrow right here on this proximal row, all right, you have the scaphoid right here, right? And you can see that the scaphoid at a certain point becomes convex. Then you can see at a certain point it becomes concave. And this is at the medial row. So I'm talking about the articulation of the scaphoid, not with the radius. I'm talking about the articulation of the scaphoid with the medial row of carpal bones. So as you look at this, you can see how it changes reciprocally convex and concave joint surfaces. On the first carpal metacarpal joint, so we talked about the first metacarpal joint, carpal metacarpal joint being a salad joint. It contains or has what they call an anatomical stuff box. It's the articulation of the first metacarpal and the distal aspect of trapezium, as I noted earlier. So why is understanding this articulation important? Why do you need to know this? So if you're going to be assessing the component motions for flexion, and extension, or abduction and abduction of the CMC joint. Why is it important to know the articulation? So remember, when you're assessing component motions, you have to stabilize one osteostructure structure and mobilize the other osteostructure structure, right? So when we start our assessments of the carpal metacarpal joint, you will be stabilizing the trapezium. So your first metacarpal is going to be moving on the trapezium. So in the open chain position, when I move my thumb, my first metacarpal is moving on the trapezium. The osteokinematic motions for the carpal metacarpal joint are flexion, extension, abduction, adduction, and opposition. The capsular pattern is abduction followed by extension. So there's going to be a greater limitation of abduction followed by extension if someone has joint pathology at the carpal metacarpal joint. All right. So when we go back and talk about flexion, extension, abduction, adduction, and opposition, make sure that you know how to make those motions. All right. Make sure that you know those. These trip students up in the practicals. So make sure you know that flexion is moving your first metacarpal towards your fifth metacarpal. All right. So that's flexion. Extension is moving your CMC joint away, going in the opposite direction of flexion. Okay. Now abduction is different. Abduction is moving your first metacarpal away from, moving it away from your second metacarpal. So moving away like so, and going back towards that is adduction. All right, the carpal metacarpal joint, loose pack position is considered midway between abduction, adduction and flexion, and extension. So your midway point between those movements. And the closed pack position for the CMC joint is full opposition. All right, here's your loose pack position. This is a visual. And this is your closed pack position for the thumb. Thumb being in opposition, closed pack position. Now we're talking about the distal radial order joint. So the distal radial order joint, the loose pack position is 10 degrees of supination. The closed pack position is 5 degrees of supination. So we got the loose pack position being 10 degrees of supination, the closed pack position being 5 degrees of supination at the distal radial order joint. So this is a visual going from 90 and considered negative 90 to 0 degrees. So this is considered 0 degrees right here between supination and pronation. And then if you go and turn it all the way back down, your hand down like this, then that would be 90 degrees of pronation. So in our distal radial order joint, what do we have? So we have concave ulnar notch of the radius. You may want to go back and look at your skeletons to visualize this, to commit it to the long-term memory. And you have the convex ulnar head. So you're going to have, with the concave ulnar notch of the radius, moving on the convex radial head, your OK and AK motions are going to be in the same direction because you have concave moving on convex. So whenever you have concave moving on convex, your osteokinematic motion and AK motion is going to be in the same direction. So therefore, with pronation, you're going to get an anterior roll, anterior glide. With supination, you get a posterior roll and a posterior glide. Now this is a visual right here. So this is just a visual of this content, right? So with pronation, you get an anterior roll, anterior glide. Supination, you get a posterior roll, posterior glide. But this is the visual showing you what you get with each of those. So again, this is your diagram of pronation. Pronation right here, showing the radius moving anteriorly and rolling anteriorly on the ulnar, on the fixed ulnar, Therefore, this slide represents an interior slide with an interior roll and swing with pronation. So right here, right, I'm pronated, okay? I'm supinated in an anatomical position. So as I pronate, the radius is swinging and rolling anteriorly as I go into pronation. So as I go into pronation, so look at me, as I go into pronation, my radius is swinging and rolling anteriorly. And it's also gliding anteriorly, all right? So if I go from pronation to supination, I get a posterior swing and roll of the radius. So now my radius is moving posteriorly, swinging posteriorly with a posterior glide or slide. So that's something you have to visualize. So you can get Charlie and get the form and visualize that and look at that. The proximal radial order joint is going to be different at the proximal radial order joint. Why is that? So at the proximal radial order joint, you have the convex surface of the radius moving on where? Concave surface of the fixed order. So now your OK and AK is going to be in the opposite direction for the proximal radial order joint. So now at the proximal radial order joint, here we go. So if I'm going into, so I'm supinated right now, right? Am I at the proximal radial order joint? So I'm going to go into pronation. So now with pronation, I get an anterior swing, anterior roll with a posterior glide, proximally. So it's going to change proximally. Now, I'm coming from pronation, right? And I'm going into supination at the proximal radial order joint. So I go into supination, I get a posterior swing and roll proximally, but I'm going to get an anterior glide. This is at the proximal radial order joint. So at the proximal radial order joint, your OK and AK are in the opposite direction. At the distal radial order joint, your OK and AK are in the same direction. All right, so moving on to the radiocarpal joint, the foundational content for osteokinematic and orthokinematic motion. So again, with our convex concave rule, we have the proximal row of carpals being convex, moving on the distal concavity of the radius. So now our OK and AK are going to occur in opposite directions. So with flexion at the wrist, you're going to get an anterior swing and roll with a posterior slide or glide. With extension, you get a posterior swing or roll, a posterior swing and roll with an anterior slide or glide. And then with ulnar deviation, you get what they call an ulnar roll or ulnar swing with a radial slide or glide. And with radial deviation, you get a radial roll and swing with an ulnar slide or glide. So your orthokinematics is going to occur in the opposite direction of your osteokinematic motion. And here's a visual. So you got a visual of ulnar deviation and radial deviation, where radial deviation presents with an ulnar slide or glide, and ulnar deviation, the person is going to have a radial slide or glide. Now, when we talk about the anatomical position, right, radial and ulnar can be interchanged. So if I'm performing radial deviation, right, what else can be used interchangeable for ulnar glide? Medial glide. So you can see the term medial glide, okay? If I'm performing radial deviation, you can see the term lateral glide. So now you also need to know interchangeable terminology. So sometimes language and terminology and interchangeable terminology will trip students up. Okay? So now you have to have a strong command of the interchangeable terminology as well. Alright? Alright? We did talk about our concave, convex rule with the saddle joint. So with the saddle joint, you have the movements of flexion and extension, right? You also have the movements for abduction and adduction. So when we talk about flexion and extension, the convex portion of the carpal is going to be moving on the concave portion of the first metacarpal. All right, this is what makes it a saddle joint. So again, for flexion and extension, you're going to have the convex portion of the carpal. Which carpal is that? It is the trapezium. We're going to ask you this on a practical. Somebody's going to get it. Now for abduction and adduction, the convex portion of the first metacarpal, and you have the concave portion of the trapezium articulating interacting. So what we have is the convex portion of the first metacarpal moving on the concave portion of the trapezium for abduction and adduction. I'm going to repeat that one more time because it's very important. I'm going to go back to flexion and extension. So in regards to the carpal metacarpal joint, often referred to as the CMC joint, which is a saddle joint complex, for flexion and extension, the concave portion of the first metacarpal is going to be moving on the convex portion of the trapezium. For abduction and adduction, the convex portion of the first metacarpal is going to be moving on the concave portion of the trapezium. Therefore, for flexion and extension, the osteokinematic motion and orthokinematic motion are going to be in the same direction for flexion and extension. The osteokinematic motions and orthokinematic motions are going to be in the opposite direction for abduction and adduction. So therefore, for flexion, you're going to get an anterior medial swing and roll with an anterior medial glide or slide. Now, it's saying anterior medial, but you want to put in parentheses, specifically medial glide or slide with a medial swing and roll with flexion and extension. So with flexion, medial swing and roll with a medial glide. That's flexion, right? With extension, a lateral swing and roll with a lateral glide occurring. That's with CMC extension. Now, with abduction, the OK and AK are going to occur in the opposite direction. So this can be a little tricky, but follow me. So this is abduction, all right? So abduction, moving away from the midline or moving away from the second metacarpal, all right, with abduction. So with abduction, the swing is going to be a lateral swing in a sense, or it's an anterior lateral swing and roll with a posterior lateral glide or slide. And then with adduction, you get a posterior medial swing and roll with an anterior lateral glide, or you can say lateral glide.
Abduction and abduction occur on the medial lateral axis.
Hold right there. Extrapolate, Dr. Carter. So adduction occurs around medial lateral axis, right? So we talk about anatomical position because they're basing this off the anatomical position. So this is unique, right? Because typically, what movements occur around the medial lateral axis? typically flexion and extension, right? So now, but we're talking about the saddle joint here, right? So follow me. So I'm in an anatomical position. Typically flexion and extension occurs around a medial lateral axis, right? But now, in an anatomical position, so this would be, so flexion would be an anterior swing and roll with abduction, abduction of the CMC. So abduction of the CMC would be an anterior swing and roll with what kind of glide? With a posterior glide, right? We're gonna learn that in lab. So we got a anterior or ventral swing and roll with a posterior / dorsal glide or slide. Because it's a saddle joint. All right? So that's good to know. So OK, AK, in opposite direction. Now, if you know that, then you know flexion and extension, right? If you know that, you know flexion and extension. But this is with, I'm gonna erase this so nobody gets confused. All right? All of this should make sense, all my arrows. So now, this is what I've done. Because you can easily get confused, students can. Notice I wrote CMC abduction. I came up with a little pattern. Wrote CMC abduction. I drew an arrow down. OK and AK are in opposite direction. All right, opposite direction. But what I want you to do with this? What I want you to do with this, Andrew? So in the textbook, we extrapolated. So this is what you have to do with the textbook. You have to extrapolate. I extrapolated. I said, okay, if I can get my axis and go back to the anatomical position, I can be sure that I'm sure based on what I know. All right. So medial lateral axis. So in an anatomical position, since this is a saddle joint, abduction is moving and swinging the osseous structure of the first metacarpal, right? This is first metacarpal. It's swinging and rolling anteriorly or ventrally. Those are interchangeable terms, okay? So this would be the first metacarpal, right? Now, this would be my OK. This would be my AK, all right? So now, I'm going to improve that motion, or a motion that, the component motion, or joint accessory motion that is necessary for CMC abduction is the posterior / dorsal glide or slide. You want to write that down. Now, because you can take this and apply. You can write this same diagram for CMC adduction, right? And you could come back and you should be able to write it for CMC flexion. You should come back and be able to write it for CMC extension. That should be on your homework list. So we can see with flexion, we can see the medial swing and roll of the first metacarpal with the medial slide or glide. So you can see the OK and AK occurring in the same direction. Okay, so getting to our metacarpophalangeal joints. Those are digits 2 through 5. So with our metacarpophalangeal joints, in our proximal interphalangeal joints and our distal interphalangeal joints, all of those are gonna be convex, concave roof. So all of them are gonna be concave surface moving on the convex surface. So if you have a concave surface moving on the convex surface, our concave convex rule is that when concave is moving on convex, then our OK and AK is in the same direction. So for flexion, extension, abduction, all of those orthokinematic motions are going to be in the same direction. So for flexion, right? So if I flex and I make a fist, I'm making a fist. So at the MCP, PIP, and DIP, I have flexion when I make a fist. Flexion is occurring, right? So flexion is an interior swing and move of each of those metacarpals, each of the phalanx. So proximal phalanx, middle phalanx, distal phalanx, all of them are moving interiorly with flexion. Now, since they are moving interiorly, right, an anterior glide or slide is necessary to complete those motions. Does that make sense? I see some head not saying yes. Yes, because you have concave, again, moving on convex, in which an anterior glide would be necessary to complete making a full fist, to complete flexion at each of those articulations. So with flexion, you get a volar glide. So volar glide is the same way. Anterior. Dorsal glide is the same way, which is necessary for extension. So the posterior glide is necessary for extension. It's the component motion necessary for extension of the MCP, PIP, and DIP. And here are your visuals. So you got flexion with an anterior or ventral roll and swing, and then you're gonna get an anterior or ventral slide or glide. Same thing as the proximal and distal interphalangeal joints. So I'm not gonna go through these because I just talked about all of them as one with the OK and AK. This is making the fist with the OK and AK, proximal interphalangeal joint, distal interphalangeal joint, MCP joint. All right. Now we're at the joint muscle actions. So joint muscle actions, knowing the muscle actions is foundational content. You must know the joint muscle actions as a PT. So with flexion, the muscles that act together to perform flexion is flexor carpi radialis, flexor carpi ornaris, and palmaris longus. Not everyone has a palmaris longus muscle, some do. You can see those differences when you dissect your cadavers. With extension, the extensor carpi radialis longus, extensor carpi radialis brevis, and also the extensor carpi ornaris, they act together to perform extension. So all these muscles concentrically contract to perform these motions. Now, what if I isolated and performed a concentric contraction of the flexor carpi radialis and the extensor carpi radialis? What movement do I get? You get radial deviation. So now you have to know that the flexor carpi radialis and the ulnar carpi radialis, they act together to perform radial deviation. So these little tidbits that you have to know for examination purposes, evaluation, differential diagnosis, and stuff for. This is just a visual of your joint muscle action, okay, at the wrist. And so again, we talked about this radial deviation, or briefly, radial deviation. You have extensor carpi radialis longus and brevis acting with flexor carpi radialis. Now, the extensor carpi longus and brevis does play a role, but not majority of it. So when you see those questions, like most likely, like which muscles are most responsible for. So you would see questions like that with most highlighted. So then you have to know, okay, what is most going to be responsible for radial deviation is extensor carpi radialis longus and brevis, along with flexor carpi radialis. But extensor pollicis longus and brevis does play a role, but not majority of those muscle fibers are going to contribute to radial deviation. Most of the muscle fibers that are going to be responsible for it are your top two muscles listed. Does that make sense? Because you have to know this content when you see those questions with most or least. Most responsible, least responsible, most likely, least likely, all right, type of question. And then with odor deviation, we get extensor carpi ordinaris and flexor carpi ordinaris acting together to perform odor deviation. All right, carpal metacarpal thumb joint muscle action. So with flexion, what muscles predominantly produce flexion? That would be flexor pollicis longus and brevis, along with opponens pollicis. And the muscles that predominantly produce extension at the CMC joint are your extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ordinaris. For abduction of the CMC joint, the abductor pollicis longus and brevis are going to be the primary muscles producing abduction, and the primary muscle producing adduction is the adductor pollicis. And these are visuals of those. All right. Here you'll see the adductor pollicis right here. This adductor pollicis, abductor pollicis brevis right here. Right here you can see flexor pollicis brevis, and then deep two abductor pollicis brevis is opponens pollicis. And then on the other side, on the other picture, you see the adductor pollicis and also the first distal interosseous. So now we're going to talk about the finger joint muscles. So when we talk about flexion, and we're talking about flexion, we talk about flexor digitorum profundus and superficialis. What's the difference between flexor digitorum profundus and flexor digitorum superficialis? So the difference is where they insert. So you had the flexor digitorum profundus inserted at the distal interphalangeal joint, DIP, and you had a flexor digitorum superficialis inserted at the PIP. Now that makes a big difference of knowing that anatomy. Why in the world would that make a big difference? So that knowing that plays a big role in your muscle testing, your muscle selective tension testing. It's also going to play a role in you identifying certain pathologies. It's going to help with the performance of certain special tests. All right. So make sure you know the difference between the flexor digitorum profundus and superficialis muscles and their insertion. And also, I didn't go through this on this slide, but you need to know the innervations too. That's in your reading assignment, okay? So also flexion, you get flexor digiti mini interossei and lumbricals. So now understanding these muscle actions is very, very, very important, right? It has been said that if you have tight and weak interossei and lumbricals, you're going to have poor grip strength. Why in the world would that be? So the interossei and lumbricals perform flexion, right? And flexion is required for making a fist. It's required for gripping, right? So if those muscles are tight and weak, they can be, the person could have poor grip strength, okay? So it's important to know that. Also, the person can have difficulty with performing full extension of the hand, which will result in eccentric strengthening or deficit with eccentric strengthening when it comes to grip as well. Okay? For extension, extensor digitorum communis, extensor indicis, and extensor digiti minimi are your primary muscles that work together to perform extension of your finger muscles. This is a visual for the muscles and tendons of the hands. You all can go back and look at this independently. So for abduction, you got your dorsal interossei and your abductor digiti minimi. And for adduction, your palmar interossei. Alright, this is a visual for visual learners. Go back and look at those. Wrist joint complex average adult range of motion values. So flexion, typically 0 to 80 degrees is your normal adult range of motion. For extension, 0 to 70 degrees. For radial deviation, 0 to 20 degrees. And for polar deviation, 0 to 30 degrees. Carpal metacarpal average adult range of motion values. For abduction, 0 to 70 degrees. For flexion, 0 to 15 degrees. For extension, 0 to 20 degrees. And for opposition, the tip of the thumb base of the fifth digit. For metacarpal phalangeal, average adult range of motion values is 0 to 50 degrees. For interphalangeal, average adult range of motion values, flexion is 0 to 80 degrees. For your metacarpal phalangeal digits, second through fifth digit, the average adult range of motion values is 0 to 90 degrees for flexion and 0 to 45 degrees for hybrid extension. Proximal interphalangeal digits 2 through 5, your average adult range of motion values is 0 to 100 degrees. And for your distal interphalangeal digits second through fifth, average adult range of motion values is 0 to 90 degrees for flexion and 0 to 10 degrees for hybrid extension. And then on to special tests. So we have wrist hand special test outlined. So ligamentous instability test is going to be your collateral ligament instability test that we're going to look at. For vascular inefficiency, Allen test and capillary refill test. For contractures and tightness, we got the Nair-Lipton test and the tight radicular ligament test. For neurological dysfunction, for nerve involvement, carpal compression test. This is a median nerve compression test. The Fromm's sign, Phelan's test, and Tennelle sign. And Finkelstein test, we'll go through this. Grind test, Murphy test. References.